Morning, morning everyone. Just checking everything looks if it's good this end. Absolutely tipping it down here as well, Steph. Good morning. Just pop a message in the chat there. Everything looks if it's working. Cool. So we're going to crack on with the last section of the sciatica kind of module that we've been doing. And just want to recap on a couple of things before we go into that, and just tie all that off. So hopefully that what we looked at last week made a bit of sense, and the reason why people have the symptoms that they do, and why it's often quite confusing and mixed up with all sorts of other stuff, because it's not very simple. That's the kind of crux of it, really. So let's get going with that. So we did this last time, but just want to recap this a little bit again before we get going. And before we do that, I wanted to recap this video here. Okay, so when we're talking about nerve root irritation, that kind of thing, I'm going to just go over where the nerve root is again and where it emerges, so you can kind of imagine what's going on. So let's just get my arrow there. So these are the little rootlets coming off of the spinal cord, and then they come together to form the nerve root. And you can see here's the dura on the outside that kind of wraps around the whole of the spinal cord. And then as it emerges, so through that gap just there, it will come out here, and this is the area where things get irritated. Okay, and at the moment we've just looked at mechanical irritation. So if there's bits of bone, so osteophytic growth, there might be ligament hypertrophy. So classic of that is ligamentum flavum usually, but it can be any of the other ligaments as well. If you've been involved in a car accident and part of your spine has been rapidly stretched, that can stretch the ligaments, and then the ligaments then lay down more connective tissue, and the ligament gets thicker. So then it closes up the space. So it could be something that happens over time. What else did we say? Fat, could be fat within this area here. I mean, this has been all cleaned out, but you can see there's not much room anyway, even when it's all been cleared out. So let alone with bits of kind of body parts in there as well as we get older. Okay, so these are the bits that we're talking about. So there's your facet joint. Just taking the facet off so you can see where the nerve root goes through. There you go. So it's around this area where a herniation will usually occur and mechanical irritation will usually occur. Okay, so it's this region here. Cool, there you go. So there's your dorsal root ganglion. We were talking about that before as well, about being an area where there may be some kind of irritation on the DRG. And then again, you can see it with everything back on there. Okay, so yeah, as it's coming out here, we've got a mixed nerve. We talked about this over the last few weeks. So it's both sensory and motor. And again, I was taught years ago that if the compression of the nerve is more superficial, then you're likely to get a sensory deprivation or changes, some kind of sensory changes. If it's kind of going deeper into the nerve, squashing the whole thing, then it's motor. But I've since found out that that's not the case. So it's a lot more complicated than that. So if you've been told that as well, then unfortunately that's not the case. It's not as simple as that. That yeah, the more you squish it, the more it's impacting the motor. It's like it was like the cords for motor were traveling in the center of the nerve root, and that's just not true. Okay, cool. So that I just wanted you to see that before we do this. So we talked about this last time, a mechanical irritation of bowstringing of the nerve root itself. So something pushing against the nerve root and causing a bend in it, just as if you were to push this guide rope here. Yeah, so if you push that rope, then it causes a deformation of it, and what it will do is it will elongate the top part of the arch and then compress the bottom part of the arch. So you'll get an irritation to the structure. And that will be exactly the same with the nerve. We'll get a deformation of the nerve as well. We can get compression. Again, we talked about this last time as well. So this is what we usually imagine is happening with a nerve root with a herniation. Okay, so it's basically is being squished by something. Actually, we looked at all of these things that can affect it. So we've got fat that can infiltrate into that nerve root area where the nerve emerges, which you've just seen on the video. We can have these little osteophytes grow. So as we get older, we get these little bits of bone growth, and they can grow into the joint space. Ligament hypertrophy, so the ligament grows in size, and then there may be a change to the blood supply as well, okay, around that particular region. So with mechanical irritation then, basically what we get is the propulsion of a nerve impulse along the axon requires energy. So to get signals from here to here requires energy along this axon in the middle. Mechanical deformation of a nerve causes a conduction block. So basically you're not able to get the message down the axon. Okay, so that's why we have these changes. So whether it's information going to the periphery, so motor nerves, or information coming back, so sensory nerves, there can be a deformation to both or either or none. Okay, so it depends. The nerve can't function, and then the impulse just fizzles out. Okay, so it just doesn't really go anywhere. Okay, a bit like a damp, firework. Okay, so then we looked at the different types of mechanical pressure, reversible and irreversible blocks. And we've probably all experienced reversible blocks, something like this, where you cross your leg over, you compress your common peroneal nerve around by the fibular head, and then it makes the outside of your foot and down the side of your leg go a bit numb. Okay, and then as soon as you move your leg, it's all good. Okay, so it's all sorts itself out again. So that's a reversible conduction block. Another one may be that been sitting on the loo for too long and your legs go numb. Okay, yeah, so it's like common things like that are good examples of reversible ones. So basically, what's happening is the blood supply to the nerve. So blood is under high pressure, oxygen is used by the nerve, and then obviously it's low pressure on the way out. And then if we've got all of these things impeding the drainage, so we've got bits of ligament, bits of bone, bits of fat, then it's harder for the nerve to get the blood it needs. So, and then what we get is because of all the congestion in there, the blood struggles to get out. So we get a venous congestion. And then we've got blood trying to get in, and then it's all kind of pooled and blood can't get out. So then that creates edema around the nerve itself. So further compression. Yeah, so this is a good example of that. So your blood's struggling to get out. We get a buildup of fluid. Then we get mechanical pressure. Then we get venous congestion. Then we get swelling. Then we get mechanical pressure. So it's this constant cycle that if you don't break it, then it can cause irreversible conduction problems. So this is another one where we've got a reversible conduction block. So it's a Phelan's test. So if you compress the median nerve in this position, usually hold it for about 30 seconds to a minute, and then it will make your fingers go tingly if there's a problem. But then as soon as you release it, it feels okay again. Yeah. So, however, if that compression is permanent, then it will create permanent changes to the nerve. Okay. So with a reversible one, there's no underlying structural damage to the nerve, and then once the edema is gone, everything's good. Or once the compression's gone, if it's the Phelan's or the crossing the leg. Okay, so all is good. If you've got an irreversible conduction block, then we've got a problem. So we've got all of this stuff potentially causing congestion. We've got the venous congestion occurring again. But now obviously the blood is struggling to get in. Just move that up there. So blood struggling to get in under high pressure, but pushing into a space that's already full. Lots of fluid in that region as well. So now the nerve can't get oxygenated blood, and nerves are very blood hungry. So we get ischemia. And ischemia is defined as an insufficient supply of oxygen to the tissue to meet the demands. So the nerve becomes ischemic, and that is not good, because without blood, the myelin sheath and the axon will die. Okay, so if this is something that goes on for a long period of time, eventually you will lose, or that nerve will lose the ability to propagate an impulse. Okay, so this is why getting people seen quick with nerve symptoms is really important. So you need to test them. Okay, and again, if you don't know how to test them, you send them to someone who does. And it's the radiculopathy testing that we were talking about a couple of weeks ago. The differences between radiculopathy, radicular. So radiculopathy is a loss of reflexes, loss of strength, loss of sensation. Okay, so we need to test those. We need to test reflexes, test strength, test sensation. And if there's a deficit, then we need to get that person seen as quickly as possible. And they will usually be scanned pretty much straight away. And again, depending on where the problem is, and operated on pretty quickly. Okay, if there is a potential that there is a compression of a nerve for a long period of time. So time is critical. With this example, you'll recover quickly after moving around. With this example, you won't. Moving around won't help. Surgery is needed. Okay, so you have to have surgery. If those nerves continue to be compressed for a long period of time, you will, especially in cauda equina, you will lose the ability to control your bowel and your bladder, and you may even have paralysis. So it can be really, really serious, and that's why we need to keep an eye out for it. Okay. So this is something that I mentioned before, and one of the things that we looked at with the disc herniations that isn't on this list. Okay, and I said it's interesting that it's not, because this is a list of people who have been scanned who are asymptomatic, so they don't have any back pain. Okay, these are the years across the top, and then these are the conditions that were seen on MRI and were noted by the radiographer, and these are the percentages depending on your age of who has them. Asymptomatic, so they don't have any pain. Okay, so these could be considered normal findings. Yeah, so people without any pain, they just scan them to see what their backs look like, and this is what they found. So if you have someone come to you who's 50 years old and they have back pain, and you get them sent off, or they want to have an MRI, if we have a look at here, we've got disc degeneration 80%. So 8 out of 10 people who are 50 who don't have any pain have disc degeneration. It's entirely a normal process. What isn't on here is disc sequestration. Okay, so if you remember that from a couple of weeks ago, it's where a bit of the disc comes off, and apparently, according to Tom Jessen, he was saying that he's found research to show that that is nearly always painful. Okay, which is interesting, because all of these things, these occur in people with no pain, but you'll see sequestration isn't on the list. Okay, but this also shows why we adapt to things. Okay, so if you can, let's have a look at this. So we've got a disc bulge, happens in 60% of 50-year-olds. So 6 out of 10 50-year-olds. The slower the compression over weeks and months, the better the body is at adapting to the changes. So that disc bulge there, it might be quite big, but if it's happened slowly over time, and there wasn't just one big inciting event like foot fell over or had a car accident or something, then the body has then had time to adapt and shift and grow new tissue to protect certain areas, and that it's just adapted to that particular disc bulge, and it's not causing a problem. Okay, if it's quite a quick change, quite a quick compression, then maybe that would be a different story. Okay, so we've covered mechanical irritation. The thing that we haven't looked at is chemical, and we've got chemical irritation from the disc itself. So the disc contents aren't supposed to meet the rest of the body. Yeah, they're supposed to be encased in that disc and not be picked up by anything else. However, obviously we know that it does meet other bits of the body from time to time, and we've got pro-inflammatory chemicals emerging from the disc which irritate the nerves in that area, and that creates an immune system response. Okay, so the body will treat the foreign material like an invader. Okay, and it will start to attack it and break it down like it would with any kind of infection. So or infiltration of any like weird chemical structure. So what have we got around it? We've got surrounding structures. We've got the facet joints, and there could be a tumour in the region as well. We could have a joint irritation. Malignant tumours also release inflammatory chemicals, and neighbouring structures can chemically irritate the nerve as well. So we've got lots of different reasons why the nerve might get irritated. It's not always a nasty one. It can sometimes be quite benign. Okay, so it may not be too much of an issue at all. So chemical irritation you can also get, just move me over there, from mechanical pressure. So say, haven't we just talked about this? Yes, we have. So mechanical pressure causes this crowding out, bowstringing, compression, all those things that we were just talking about, that can irritate the nerve and cause an inflammatory response, a chemical response to the mechanical pressure. Okay, so there can be a chemical reason for the symptoms, for the pain, not just mechanical. So does a disc herniation cause pain? Maybe. It depends. Okay, and hopefully you've seen that as we've gone through. It's a bit more complicated than A equals B. So this is the last slide on this. So extrusions were linked to 26% of people with radicular pain and only 1% of asymptomatic. So if you have an extrusion, you're more likely to have symptoms. Okay, and that came from this paper here. It's back in 1994. It'll be interesting to see if there's anything new that's come out. Some have radicular pain but no herniation. Okay, so they've got symptoms down their leg, but there isn't herniation at all. And that can be because of a number of reasons. And again, we've talked about this. So it could be the MRI isn't sensitive enough to pick it up. So there could be annular fissures, a dynamic herniation. So it's not picked up when you're supine. It's only picked up when you're stood. So you might need a standing MRI instead of a lying down one. The problem might not be the spine. Deep gluteal syndrome can radiate down the leg and give you radicular symptoms. So it doesn't necessarily need to be coming from a disc. The problem might have gone. So it's taken so long for the imaging that the anatomy has, the anatomical cause has changed, but the chemical irritation is still there. Okay, and you can't image chemical irritation, you can't see it. So there may have been a disc bulge that is then since reduced. It's taken like 12 weeks to get a scan, and during that 12 weeks, it's reduced far enough that it doesn't look as if it's compressing anything anymore. So they look at it and they go, well, there's no compression. Yeah, so that could be a reason as well. So that's the kind of summary of sciatica. Key things are you need to be able to, the questioning about loss of sensation, loss of motor control, and loss of reflexes. Those three things are really key. They need to be tested early, and even if you're not sure, because it may be that if you do a reflex test and you haven't done one for ages, you're just not very good at doing it. So you think it's a positive test, just send them anyway. Okay, because if you're right, then great, and if you're wrong, it doesn't matter. They've been checked out. Okay, and at least you've erred on the side of caution. If that person's nerve stays compressed for any length of time, they will lose the ability to use that nerve. Okay, and there was something, I think I posted it in our group a little while ago, and it was about people suing people because they've lost control of their bladder or their bowel because cauda equina wasn't picked up by the person that they saw. Okay, now we're not saying like everybody should be able to know how to examine for it, but you should certainly know to ask, have you lost sensation? Have you lost power? And if you can't do reflex tests, then you need to get them done. Yeah, so that's where safety netting comes in, and I posted about that a few weeks ago. Okay, cool. So that's sciatica. Took a little bit longer than I thought it was going, but there we go. So we're going to move into now, and if you've not done any kind of Learn Anatomy online, or this is your first section of it, we then start to move through the body. So our next section is going to be the thoracic spine. So we're going to look at that. We're going to look at the bones and the joints. So today we'll have a look at the thoracics and the ribs, and then we'll start to add on the soft tissue layers. So the ligaments, and then the muscles, and then the blood supply and the nerve supply. Okay, so that's the plan. Moving on to thoracics over the next few weeks. So here we go. Just move me out of the way. If you've got any questions about sciatica, pop them in the chat. Happy to do those as we go, or if it kind of takes us off on a tangent, I'll answer it in the group a little bit later. So key terminology for you for this particular section is costal means rib. Okay, so you might have heard of the costals before, or intercostal muscles. Just basically means in between the ribs. Okay, TX is shorthand for thoracic vertebra. Again, if you've not heard that before, LX is lumbars and CX is cervicals. So TX is thoracic, so we'll be obviously looking at those. Facet joints are called zygapophyseal joints, okay, in the spine. That's their official name, zygapophyseal. Facets mean little faces. So they're very, very smooth joints. We've just seen them in the lumbars. They're slightly orientated differently in the thoracics. Okay. Transverse processes are side sticky out bits. Spinous processes are spine sticky out bits. So they're going backwards towards you, the outside of your body. And then pedicle means little feet. Okay, and again, you'll see why certain bits of the spine are called that. So we have a vertebral body, and then the pedicles come off of that, so they look like little feet coming off of the body. Okay, cool. So those are the key bits of terminology that you need if you've never looked at this area before. And then we looked at the functions of the spine. We did this previously with the lumbars, but we're going to obviously have a bit more of a focus on the thoracics this time. We've got contains and protects spinal cord and the nerve roots, which is what we've been looking at over the last few weeks. Supports your body weight. The curves of the spine allow movement to be distributed so that the muscles can work most efficiently. And then it also allows freedom of movement. So they're not like hinge joints, condyloid joints, or given a specific name. They're called irregular. Yeah, and it's because they are irregular in their shape. They've got lots of different joins, and it depends on which bit of the body they're in as to which bits they join to. Okay, so that they'll have you'll find additional bits to the thoracic vertebra that you don't have in the lumbars. And then again, same for the cervical spine as well. Okay, so there'll be bits in certain areas, and the shape of them will help determine the movement that is available at that particular vertebra. So, for example, in the lumbar spine, if you remember this going back a long time now, but the facet joints, the zygapophyseal joints, are side by side. So you can't rotate very much. They don't rotate. But what they do is they flex and extend really well. Okay, so in the thoracics, they're orientated completely differently. They're kind of like on top of each other, a bit like roof tiles. Okay, so they slide on like roof tiles, so they can slide across each other and they can rotate really quite well. They can also glide forward and glide back. So we've got good flexion and extension and rotation, but we're limited in rotation because of something else. So in the thoracic, so we'll talk about that. Is there a shock absorber or a shock distributor, okay, from perturbations from the external environment. So any kind of forces that come into the body as a whole, the spine is able to distribute those forces, okay, via the connective tissue, via the ligaments, via the discs, via the other bony structures that are in that area. There's loads of different distribution channels, okay, and also provides a surface area for muscle attachments. So there are specific points where the muscles will attach, and that is how we get our bony growths. Okay, so bony landmarks come from attachments of muscles, and it's over time as those muscles develop and they pull on those bony landmarks that they become landmarks, because of the as the bone gets pulled away, it fills in with more bone. So you'll find this on big muscles like the quads, where on the tibial tuberosity, as the patellar tendon is pulling on the tibia, it starts to pull away at the bone, and then you'll get more bone laid down, and then that creates your tibial tuberosity over time. Okay, and then again, your body will adapt as well. So if you're a right-footed football player or play basketball or whatever it is you do, you usually have a much bigger tibial tuberosity on your left leg, because it is the standing leg or the jumping leg, than you do on your right, which is a bit weird because that's your kicking leg, if you like, if you play football. But actually the left leg tibial tuberosity is usually bigger. Okay, and that's the same in the spine, so around the occipital ridge. So you've got this big ridge on the base of your skull where your trapezius muscles attach into. They're huge muscles, okay, and they'll pull and pull. If you have small children in your family at the moment, if you have a feel of their skull, it will be nice and smooth, and then compare that to your own skull and it will be full of bobbles. Okay, so we've got the marks of development, and babies have yet to develop those bony landmarks yet, because they're not walking. Okay, cool. So these are the angles at which the facet joints join each other. So we've already done this one. So this was the lumbar spine. I remember I was saying they're side by side, so that limits the rotation. So they're very good at flexing and extending, but they're not very good at rotating. With the thoracic spine, they're more like roof tiles. So you can see, where's that gone there? Okay, so you can see the angle just here, a bit, but 60-degree kind of angle. And the next one is obviously underneath that, and then there's one on top. And look at the slope of that facet joint just there and just there. Okay, so that's the angle which they glide across each other. Whereas in the lumbars, there's no glide side to side. It's just straight forward and back. Okay, you get like 1 degree of rotation in each lumbar vertebra. Cool, and then we'll talk about cervicals when we get to the neck. Okay, so in the thoracic spine, so that this region here, the available movements are rotation, so we can rotate around. We can extend, so we can bring arch our back. We can side bend, so we can laterally flex, and we can bend forward, which is flexion. Okay, these movements occur in varying degrees throughout the different sections of the spine, but in the lumbars, you can't really laterally flex and you can't really rotate. But flexion and extension, no problem at all. In the thoracic region, so that kind of upper back area, we can do all of these, except that we're limited in rotation somewhat and side bending because of ribs. Okay, so not the vertebra themselves, but the ribs get in the way of rotation and side bend. So the thoracics is very good at flexing and extending again, and it can rotate and side bend, but just not as much as the neck, because the neck doesn't have any ribs getting in the way. Okay, whereas the thorax does. Okay, so some of our movements are limited depending on the structure. So excuse me if I'm teaching some of you to suck eggs, but we'll go from the basics. The structure of the thoracic spine is that it usually has a kyphotic curve, so it curves outwards. Okay, so if you think about a hunchback, that's a very exaggerated version of that curve. But that's usual. It should usually curve outwards. There are usually 12 vertebrae. Okay, and again, we know that from the lumbars that there can be more and there can be less, and they are paired with 12 ribs. So for every thoracic vertebra, there is an adjoining rib. Okay, so we've got the similar kind of structure all the way through the thoracics, except the ribs change as you go down. Okay, and we'll talk about that as we go. Okay. So the thoracic vertebral features, we've got costovertebral joints. So if we think about what that means, remember costo means rib, and then vertebra is obviously the vertebra. So we've got a join, an articulation between the superior and inferior costal facets of the thoracics and the ribs. Okay, so there's a superior and inferior rib facet joint of the thoracics and the ribs. So the rib joins to both there are several connections on the thoracic vertebra where it attaches. Okay? And that differs depending on what level that it's at. So the rib will move differently depending if it's lower, or if it's in the mid, or if it's upper. Okay, so that there'll be changes as we go. Then we've got costo-transverse joints. So costo is to do with ribs. Transverse is the transverse process. So there's an articulation, so a join, between the transverse costal facets of the thoracic and the posterior surface of the rib. Okay, so where there's a sticky out bit on the ribs, which we'll have a look at in a second, there's a join there where the rib attaches to. Okay, so not only does it attach to the vertebra itself, but it also attaches to the transverse process as it's making its way out and around to join at the front. In the thoracic spine, there is a larger transverse process than there is in the lumbars. And there's a long oblique spinous process. So it's like a witch's nose, points downwards. So we'll have a look at that. Here we go. So here's your long spinous process, just here. There's your vertebral body. There is a superior, so above, costal rib facet, so joint, basically, okay? So that bit there joins onto a rib. Okay, this bit here is a transverse, because it's on the transverse process, costal rib facet joint. Okay, so there's a join here and a join here. So the rib attaches to both of those attachment points as it makes its way around and curves around to the front of the body. Okay, this is a nice view from above here. So we've got a superior costal facet just there. Then there's the transverse costal facets. That's the same as those two that we've just looked at. And you can see the sweep as it comes around, and then it will join at the front for the front of the rib cage. Okay. Here's your vertebral body. So this is the body at the front. And remember I said pedicles means little feet. There's your little feet. Yeah. So there's the body. There's the little feet sticking out. Okay. These ones here, so that join there and that join there. So if we look on this model, you can see there, the top one there, and then there's another one at the bottom here. These are the joins that join the vertebra. Okay, so they join the vertebra to each other where they slot in. The other ones, so that one, and then that one, we haven't talked about that one yet, those join the ribs. So there are separate facet joints for the ribs and for the vertebra, because they do different things. Okay, so obviously the rib cage needs to move with our breathing, and then the facet joints need to be able to move to allow our spinal movements. So they both do different jobs, and they've all got their own little joint space. Okay, this one here, the inferior costal facet, that joins with the vertebra below to form the full facet around here. So where the rib attaches, it's kind of halfway in between the vertebra. So it attaches a little bit on the one above, a little bit on the one below, and then onto the transverse process on the side, okay, as it sweeps around. So let's have a look at that in a bit more detail. Okay, so there's the vertebral body. See the transverse processes. There's the costal facet just there, you can see that. Spinous process here. These are the little facet joints. So these are the ones that attach the vertebra. And then these are the ones that attach the ribs. So that one just there and then there. So they look a bit different in real life. They're not as pronounced. Just pause that there. Okay, cool. So we've got the vertebral foramen, so that where your spinal cord will go down. So spinal cord will be there. Transverse process, so side sticky out bit. Spinous process, spine sticky out bit. Little feet, so those are your pedicles coming off of your body, just there. Okay. This area here, they've called it the neural arch. It's also called the lamina. Okay, so around this area here, and we'll see that get filled in as we progress through. So yeah, spinal cord goes down there. So that's your vertebral foramen. And there it is, just showing the how the spinal cord goes through. Yep, so this is the lamina. These are your little feet, pedicles. That's a little dip to allow the nerve root to come through, and then there's a big dip on the inferior pedicle. There you go, so you can see the nerves will come through here. So it's your intervertebral foramen, just there. There we go, I'm just going to pause that there. So can you see that bit there? There's a little dent there and a little dent there. So that is where your rib will attach, okay? Always used to make me laugh when people say that they can feel a rib head, okay? So because it's there, it's underneath your transverse processes, underneath all of the musculature that are there, underneath where the nerve root comes through, okay? You might be able to palpate here where the spine, the transverse process where the rib joins there, but there you've got no chance whatsoever of being able to palpate that. So here are the little faces again from the back. Spinous process, transverse process. Yeah, sometimes they're called articular processes or facets. Yeah, so those are inferior facets. That's the thing with anatomy. There's lots of names that are different names for the same things. So it's like, I didn't realize it was called that. There we go. There's your facet joint just there. And that's the joint in between your vertebra. Okay, cool. Right, I just want to show you this as well. So this is a bit of an introduction to the ribs. Okay, so this is a 6th rib. So you can see how curved it is, and then it's got this gully underneath it here as well. We'll talk about that later. So there's the head. Let me just pause that there. So there's the head just there. So that's the bit that attaches onto the vertebral body that I was just talking about. And then you'll have another little facet joint where it attaches onto the transverse process. Yeah. So yeah, the head articulates with the vertebra, and then the tubercle articulates with the transverse process. So in terms of palpation, that is basically on the side of your spine underneath your transverse process. Okay, that rib head. So if someone says that they can feel your rib head moving, then I'd seriously question them. Okay, we've got the angle of the rib just here, and it's nice and smooth as it comes all the way around to the front. And then at this point, it attaches to the costal cartilage because of the level of rib that it is. And the ribs will do different things depending on where they are. So very smooth on the outside. And as I mentioned before, can you see there's like a little gully? Yeah, there's a groove on the inside. And that's where, just go back a little bit. Pause that there. So that's where the groove on the inside is where the nerves and the blood supply go for the ribs. Okay, so as it emerges out of the thoracic spine, it then travels along this groove to supply all the way around to the front of the ribs. Okay, so the nerve and the blood supply. If you've ever heard of shingles, those are the nerves that are affected, and that is why it follows the line of a rib. The rash follows the line of a rib, okay, because that is the nerve that is affected. Okay, so we've got we've got this demi-articulation. Let me just go back again to that. So do you remember I was saying that we've got the top part of one vertebra, and then the bottom part of another one is where the rib attaches. So it kind of sits halfway in between the two. Where if you have a look at the shape of the joint, it's got two grooves in it. So one will attach obviously to the upper one, one will attach to the lower, and then there's a little dip in the middle where it kind of fills the gap where the disc is. Okay, so that will articulate with the vertebra, so will that, and that will go in the middle. Okay, so that's why they're shaped the way they are. There we go. Perfect. Okay, so there's the upper, there's the lower. So that's your costovertebral joint, so where the rib joins the vertebra. And then we've got this tubercle here. So tubercle just means like a lump, and then there's the tubercle perfectly fitting into the transverse process. So that's your costotransverse joint. And in this particular region, you get a bucket handle type movement of the rib because of the shape of the rib. Okay, so it kind of tips up and back down again. If I just show you the picture of that again. We'll go over this again later on. There we go. So in the upper ribs, it moves a bit more like a pump handle, and in the lower ribs, it's more like a bucket handle. So it comes out to the side like that. Okay. So because this is rib 6, that will be a bucket handle rib. Okay. Cool. What time are we at? I think that will probably be a good little introduction. Okay. Hopefully you found that useful. So yeah, finished off sciatica, moved on to the thoracics. So recap of the vertebra, recap of the joints, the ribs, and yeah, if you've got any questions between now and next week, just drop it in the group, and I'll carry on with the thoracics and then start to layer on the connective tissue. So we'll look at the ligaments around the thoracic spine, very similar to the lumbars and the cervicals in certain areas, but then because we've got the ribs, we've got some additional bits as well. Cool. I'll see you next Monday. See you at 10 o'clock. Have a good week. See ya.